It is my honor and delight to introduce to you an SSA student, James Kowalsky, who is also the project director for the Illinois Prevent Prescription Drug and Opioid Overdose-Related Deaths, or PDO grant, at the Illinois Department of Human Services in the Division of Substance Use Prevention and Recovery. He's pursuing a Master of Arts degree from SSA currently, and since 2013, James has been providing training and support to organizations adapting their practices to incorporate harm reduction, housing first, motivational interviewing, and trauma-informed care through his company Practice for Progress. Additionally, James volunteers as a super trainer for the Chicago Recovery Alliance. Please join me in welcoming James Kowalsky.
All right. Hi, everyone. Thank you for sticking around. I like to think this is a really important part of what we're here to do today. So Dr. Malik, right, said that we need to flood our community with naloxone. So today we're going to make it rain. So my name is James Kowalsky. Here's my clicker. Here's my contact information. Please reach out to me if anything in this comes up that you either are confused about or that you have questions about later or that you want assistance with. And I'll be happy to talk to you about it. Basically, my job at Super is to do everything we can to try to reduce the impact of drug overdose in the state. And particularly, I work for the PDO grant, but we have a few different projects at Super that are involved in drug overdose prevention work. So I'm just going to say a quick word. So for those of you who don't know about Super, Super is Substance Use Prevention and Recovery. We are a division within the Illinois Department of Human Services. You may be familiar with DASA. Nodding, okay. That's what we used to be called. Now we're called Super. I know it takes some getting used to, but Super used to be DASA. We're still getting over that. So basically, Super's mission is to provide a system of care along the continuum of prevention, intervention, treatment, and recovery support where individuals with substance use disorder, those in recovery, and those at risk are valued and treated with dignity, and where stigma accompanying attitudes, discrimination, and other barriers to recovery are eliminated. So what I will say is, today we're going to be talking about naloxone, or this presentation is about naloxone. And I think it's appropriate that where we started with a lot of the previous speakers was a lot more about the upstream work. Naloxone is about as downstream as we can get. Naloxone is the crisis intervention tool that we have to prevent an overdose death at kind of the last possible second. All this other work, and it's everything from our prescribing habits, but also people were talking about kind of what do we need to do in communities to become more recovery-oriented, to reduce the impact of trauma, to increase meaningful opportunities for people, to increase access to treatment services for people who are interested in changing their relationship with drugs. I think all of those are different parts of the picture. So naloxone is the part of it that I get to talk about today. So I know at trainings and presentations, sometimes people like to dip out a little early. So I put the most important thing at the very beginning. So if you are one of those people who's trying to sneak out, and don't sneak out, this whole thing is going to be interesting, I promise. And there's lunch after me, so if you leave before me, you won't get lunch. But anyway, if you are planning on leaving early, here's what the state has kind of designated as our core content for overdose responders. So once you know these 11 things, or once you are taught these 11 things, you're able to carry and administer naloxone. You're covered by state law to do so. So I'm going to kind of do the quick rundown so that you get the core content that you need in case you need to leave early. But again, don't leave early. Okay, so I'll just go through this. So the role of naloxone. Naloxone is a medication. It's an opioid antagonist, and it reverses the effects of an opioid. That's particularly helpful in the event of an overdose. So the way we can recognize a potential opioid overdose is opioid overdoses occur because of suppressed breathing. People don't get enough oxygen, and that causes them to die. Naloxone reverses the effects of the opioids and restores people's breathing. The way that we confirm that people are overdosing is by using what's called a sternal rub. So you can just do this real quick. Put your hand on your chest, that bone right there. When you rub really hard on that on someone, normally they will respond. If they're unconscious, they're not going to respond. So you can take that as the indication that they're overdosing. And the first thing you want to do is administer naloxone and call EMS, whichever one you can do first, but do both. Give naloxone and call EMS. If the person doesn't respond after 2 to 3 minutes, then you want to give an additional dose of naloxone. I'll go into more detail about all this eventually, but these are the key things. And then you want to stay with the person until medical attention arrives or until you can get them to a hospital or medical setting. If you have to leave the person unattended for any reason, you would want to put them in the rescue position. That's essentially turning them on their side so that if they throw up, they're not going to throw up in their mouth and suffocate. The Drug Overdose Prevention Program. That's what I'm secretly here to plug. I want all of you to become drug overdose prevention programs. It's a project that we run through the state, through Super, and basically it would set up your program, whether that's a hospital or a nursing home or a clinic or a outreach center or whatever, honestly, whatever you do. I promise you can be a DOP program. But basically what it means is that you can distribute naloxone directly yourself from your program. So for instance, Chicago Recovery Alliance is supplying the naloxone today that's going to be distributed. They are a DOP program as part of the state. And so we have several hundred DOP programs around the state. And they provide naloxone in the community for free. And so that is the most important stuff to know about them. Legal status of naloxone. It is legal for you to possess and administer naloxone in the event that you believe that someone is overdosing on opioids. And in terms of reports and refills, if you use your naloxone, follow up with the people who you got it from originally. Let them know what happened. We try to monitor and document all overdose responses in the state, which is a challenge, as you can imagine, and get more naloxone. Don't split up your kits. So if you have, all naloxone kits come with 2 doses and 2 syringes in them. That's because you might need to give a second dose. So don't split up the kit. Just go get more from the people you've gotten it from before. That's it. That's the core content. So you could leave now, like I said, but don't do that. So a couple things, like why is this happening? I'm going to try to breeze through some of the things that other folks have already talked about. But what I will say is it would be nice if it was just one thing, but it's not. We talk a lot about prescription opioids, but the reality is that a major factor of what's happening right now is not just opioids in general, but in particular heroin and our poisoned heroin supply. So we haven't talked much about fentanyl so far, but especially here in Chicago, we see this where the majority of opioid-involved overdose deaths, so Dr. Thompson was talking about some research here in Chicago earlier, the majority of opioid-involved overdose deaths in Chicago involve heroin and or fentanyl. And I think it's something from the 2017 statistics that about 10% involved pain relievers, so prescription opioids. So especially here in Chicago, we're dealing a lot more with the deaths coming from heroin and fentanyl use. And here you see just some of the risk factors that are kind of identified. Mental health symptoms, adverse childhood experiences that got mentioned, so kind of the role that trauma plays. We talked about pain as a vital sign before as well, and kind of the marketing associated with opioids. There's kind of a lot of different things that have contributed to the crisis, and so we're really kind of working through piece by piece. Here's just an illustration of the increase in overdose deaths, and what this shows is in 2017, over 70,000 drug overdose deaths occurred around the country. 2/3 of those involved an opioid. And so I'll say this, sometimes you'll hear involved an opioid. Most of the time when a drug overdose death occurs, there's more than one substance involved. So we say opioid-involved overdose deaths. And so one of the risk factors we'll also talk about is kind of mixing substances. I'll just skip over some of this stuff. But basically, I have a link in here, and I have the image of the IDPH website. We mentioned about how data is like an important tool that we can use to help try to figure out what we're doing to address the overdose crisis. And so IDPH has actually put together a really good opioid dashboard. And so that is what I'd like to mention about that. Oh, this is what the dashboard looks like. The website link is in the resources, or in the last section of the slide. But basically, you can find the website. And in addition, you can't read this, but up here in the top right corner, one of the tabs is naloxone distribution locations. So even if you're not here in Chicago, one thing you can do is you can look for other DOP programs in your area, drug overdose prevention programs. And you can also look for pharmacies that are carrying naloxone. So that's another way that you can access naloxone or encourage other people to access naloxone is pharmacies now carry naloxone. You do not need a prescription to get it. You just walk in and you say you'd like it, and they give it to you. I mean, they might charge you something, so That's why the DOT programs are nice. Here's the website for the opioid data dashboard. IDPH, opioids data dashboard. You'll find it. Some of the opioids, most common opioids that get used. So morphine and codeine come from the actual poppy plant. That's that green thing. Or if you remember like Dorothy running in the poppy fields, that's essentially where it comes from. And actually Dorothy is a good illustration of like what happens when people use opioids is they get calm and relaxed and sleepy, and that's why they like go to sleep a lot of the time. Semi-synthetic use some elements of the poppy plant. Heroin and oxycodone or OxyContin are kind of the most common ones we think of there. And then fully synthetic, fentanyl, methadone, buprenorphine are the most common ones. The distinction between them is not that important because the effects are very similar. What is important to know in terms of the distinctions as you start to find out what particular opioids someone who you're working with might be using is kind of the duration of the effects of the substance. And that can range a lot from one drug to another. Here's 3 waves of the rise in opioid overdose deaths. So the first wave that they talk about is the rise in prescription opioid overdose deaths. And that kind of happened from the 1990s into the 2000s. And then as we started to see kind of a restriction on the opioids, on the prescription opioid supply, that sort of led to an increase in heroin use, and heroin overdose deaths increased. And then over the last few years, what we've seen is a lot more synthetic opioids, and in particular fentanyl, being responsible for overdose deaths. So helpful to think about, I think, just what are the different kind of contributing factors. And like I mentioned, 2/3 of drug overdose deaths last year involved opioids. So that's part of why we talk about opioids so much, is they are the major contributing factor, but also because we have naloxone, which we don't have for any other drug overdose. In general, drug overdose is a complicated medical situation that requires monitoring and medical attention. But naloxone, actually, I sort of like thought of this earlier. It's sort of like if there was like a fire in your kitchen, you might use a fire extinguisher, but you'd also call 911. Like naloxone is our fire extinguisher. You should still call 911, and you should still have medical help, but good to have a fire extinguisher. Put the fire out, a little bit before they get there. What puts people at risk for overdose? So these are the biggest risk factors. Mixing drugs. So the most dangerous combinations we want to be mindful of are opioids with other opioids, but also opioids with benzodiazepines, so anti-anxiety medications. So I think we talked a little bit about like physical pain and emotional pain. And so I think people who are being treated with benzodiazepines, we want to be really mindful about what other substances they might be using to help medicate other symptoms that they're experiencing. Opioids and alcohol are another risk factor. Opioids and cocaine are another one. And I think actually opioids and cocaine get used a lot in combination because people are sort of trying to balance out the symptoms or like the effects of one or the other. So, right, I'm high on cocaine all night. The way that I'll come down at the end of the night is I'll use heroin. Or I'm on heroin, I feel myself getting too tired, I want to come up, I use cocaine. So kind of like people think that there's this balancing out, but actually what it does is it overtaxes people's system. Tolerance changes are really important. So we talked about people coming out of incarceration being a particularly high-risk group. But basically, anytime someone is dependent on an opioid and they stop using, even for just a couple of days, their tolerance can change. And so very often what will happen is people will stop using for a period of time because they go into treatment, they can't find a dealer, they run out of money, whatever it might be. And when they go back to using, their tolerance is lower. So the amount they need to get high is lower, but also the amount they need to overdose is a lot lower. So it's easier for them to overdose in that situation. So again, like one of the high risk categories would be someone who is in treatment or in recovery or someone who has recently gone to detox. Like oftentimes I think we think of those folks as like they're on the right path and they're doing the right thing. And so we don't have to be as worried about them because they're already kind of taking the steps to address the issue. And in reality, when someone, especially is early on in recovery, that's when their overdose risk is at the highest. And part of why medication is so important for treating opioid use disorder is it does lower people's overdose risk. There's variation in the strength and content of street drugs and in the strength and action of prescription drugs. Using alone is a really serious risk factor. So if nothing else, I think a lot of people end up using alone because of the stigma associated with substance use. When we talk about harm reduction, I think it's important that we incorporate into this conversation not only, I think there's kind of different arms of what we can do about the overdose crisis. We can try to prevent people from using opioids and using other illegal drugs. We can try to increase access to treatment, but we should also recognize that there are a lot of people who use illegal drugs and misuse prescription opioids that don't overdose, or that if they do overdose, that they don't die from the overdose. And so I think it's important that we're talking to people about what are the things you can do right now to make yourself safer. And one thing you can do to make yourself safer if you're using illegal drugs is don't use alone. You need someone there to call for help, right? If you're unconscious, you can't call for help for yourself. And I feel like that's really counterintuitive because a lot of what we tell people to do when they're using substances is to disconnect from their using networks. But those using networks are also the people who will be there to call for help or administer naloxone in the event that they overdose. So a challenge, we talk about balance a few times, and I think that's one more place we need balance. Physical health, and so this is particularly relevant to older adults, but in general, physical health problems increase your risk for overdose. And anything that has to do with breathing, so lung disease, asthma, but also things that have to do with like how your body processes substances, like kidney disease, all of that increases your risk for overdose, as well as things like malnutrition. Poor sleep can increase your risk for overdose. So I think that's where we see, in particular, older adults being at a higher risk. Mode of administration, if you inject drugs, you are at a greater risk of overdose, but it's important that we let people know that if you are taking pills or if you are snorting heroin, that you can still overdose from those. And I think that's kind of like an old myth that we're still getting over a little bit. Previous overdose also, if people have overdosed in the past, they are at a higher risk for overdosing in the future. So we mentioned like how our screening questions are often like, do you use drugs? Check or no, and I move on. Right? So if someone says that they currently use opioids or if they have used them in the past, it is an opportunity and an opening to have a more detailed conversation with them. So if nothing else, we can start bringing the word overdose into our conversations with people. What's your experience with overdose in your life? And they might talk about their own personal experience. They might talk about people they've worked with or people they've known and loved who have died from overdoses maybe, but creating the opening to have those conversations and say, you know what, this is a space where we can talk about overdose and where you won't be shamed or judged for the fact that you may have overdosed or you may know someone who has overdosed. Because knowing that is really helpful for us and can also lead us to really helpful conversations. So, I've talked to people who say, well, I've never overdosed and I used for 20 years. I say, wow, that's really impressive. Like, what have you done to keep yourself safe during that time? Right? We know that these drugs are dangerous, and yet somehow you've managed to avoid the most serious consequences. Help me understand what you're doing to take care of yourself. And again, putting people in that frame of mind that, like, I don't assume that you're using drugs because you're trying to harm yourself. I think that you're also trying to take care of yourself in some way. Again, like a very strengths-based approach to people's substance use. All right, so we're on to naloxone. Here's all the different ways you can put naloxone in your body. You can inject it. That's this one with the orange cap. That's what I have here. This is what you all will get today. This is what Chicago Recovery Alliance distributes. There are these auto injectors. That's that purple one there. That is one that you open up. It literally talks you through how to administer naloxone. It's pretty fancy. And then there's these two intranasal versions. So we've got the more modern intranasal version. That's nasal Narcan. That makes intranasal injection or intranasal administration very easy. So I touched on most of this already, but key things that I didn't mention already, naloxone is very safe. If you are not sure if someone is overdosing on opioids, but you think they might be, you should go ahead and give them naloxone. It's very rare that people will be allergic to it or have some kind of contraindication. And what actually happens when people get opioids in their system is kind of the negative effects is they experience opioid withdrawal. Because if they're dependent on opioids, their body's used to having opioids in those opioid receptors. When it gets kicked out, they experience withdrawal. So again, really important why we monitor people is a person's instinct when they experience opioid withdrawal is to use more opioids. So we want to be very careful in the time after administering naloxone to make sure people don't try to pick up and use more. Naloxone has a shelf life of 2 years. It has an expiration date on that. Don't throw it away. We save the unused, so a few things. It is still effective past the expiration date. So get a fresh kit, but there's some evidence that says that up to 10 years after the expiration date, it is still effective. So swap it out for a current kit if you want to, but at the very least, hold on to it. It's better than nothing. And again, it's not going to hurt a person. We're protecting from light and from extreme temperatures. So I always like carry it in my bag, but that's why they come in these brown bags like this. It lasts for about 30 to 45 minutes. So that's kind of the half-life piece. So that's why, again, it's so important to monitor people, because it is actually possible that if they have enough opioids in their system, they can go back into the overdose after the naloxone wears off. Last things, naloxone is not Suboxone or naltrexone. These things have similar sounding names, and that is confusing. Naloxone is a crisis intervention agent. Naltrexone and Suboxone are medications that are used to treat substance use disorder. This is your brain, or your opioid receptors, I should say. When you have opioids in your opioid receptors, you feel the effects of opioids, whether that's our naturally occurring opioids or the opioids that we get from pills or from heroin. Naloxone blocks those opioid receptors so that you do not feel the effects of the opioid receptor. They don't just like erase the opioids. The opioids are still floating around in your body, but you can't feel them because they're not in your opioid receptors. So it gives when naloxone comes in, it gives your body some time to process the opioids that you have in your system. Here's the difference between someone who's really high and someone who's overdosing. When people are taking opioids, their pupils are pinned, whether they're high or whether they're overdosing. So I don't really think it's particularly helpful to like peel back eyelids and like look, because that's not really the most important thing to do at that moment. Also, like old school methods of like slapping people or kicking them, like you really don't need to do that. Ice baths, dragging people into showers, all of that is only effective, or that stuff has been effective in the past, because I've had people come up and be like, but that worked. And like, it has worked, but the reason that it works is the same reason a sternum rub works, is like what you're doing is you're waking someone up and you're stimulating them. So someone who's really high on opioids will nod. So if you all know what nodding looks like, it kind of looks like the person's falling asleep. They'll drop their head and kind of catch it. But if they can still kind of communicate with you, they're arousable, they're communicative, they're probably just really high, they're not overdosing. Their speech might be slurred, and they might appear sleepy and intoxicated. If someone you believe is really high on opioids, the best thing you can do is stay with them, monitor them, continue to engage with them. If they become unresponsive, certainly, but if they are just sort of not making sense or just only able to respond with and you start like losing kind of that connection with them, then you might want to like make sure you have your naloxone kit handy. So the key thing that we're looking for is this person arousable? Talked about the sternal rub already, and not speaking. If you come upon someone and they're just sort of unconscious and you don't know what happened, other things you might look for are purple or blue lips and fingertips. You might also look for or listen for what sounds like a choking or snoring noise. It's kind of like people struggling to breathe is what you're actually hearing. Gray, cold, clammy skin. Those are kind of the other things. In that event, you want to call for help and give naloxone and do rescue breathing. I'll say a little more about that in a sec. Sometimes I put extra slides in here just to be like, really make sure we hit these things home. If you need a picture later to remember what the sternal rub is, this is your picture. So the first thing you want to do is before you start rubbing people's chests, check with them. Just say their name. If they're not responding to their name, I think another like trauma-informed strategy that I've heard is before you start touching people, also you can kick their chair. And that should like startle them and wake them up. It's a little bit less invasive than like having someone grab you and shake your shoulders. But if they're not responding to those things, move very quickly to the sternal rub. Sternal rub. Administering naloxone, giving and calling 911, whichever you can do first. These are kind of the steps. Again, pictures help. Call 911, give naloxone, rescue breathing. Basically, you'll know your naloxone kit will come with 2 doses of naloxone in it, these little orange vials. 1 vial is 1 dose. So that's easy, right? If there's an orange cap on it, it hasn't been opened and it hasn't been used yet. Once you take the orange cap off, it cannot come back on. So that's just important to know. When you snap off the cap, what you'll want to do is you'll stick the needle through the gray dark circle in the middle. You'll flip it upside down. That makes it easier to see where the fluid is. And you'll want to see the tip of the needle in the neck of the bottle. Don't put the needle all the way in, or you won't be drawing up the fluid. Put it in the neck of the bottle and draw the plunger out on the syringe. If no fluid comes in or you're not getting enough, just push the plunger right back in and draw it out again. The air pressure helps draw it out. You'll give the dose either in the shoulder or the thigh. This is an intramuscular syringe. You don't have to worry about air bubbles. And this is not Pulp Fiction. Do not put a needle in anyone's chest. Head tilt and chin lift. So basically, these are the steps for rescue breathing. You want to check the person's mouth, put a hand on their forehead, tilt their chin backwards, open the mouth, pinch, give 2 big breaths to start with, and then 1 breath every 5 seconds. Plastic mouth guards. If you're going to be doing rescue breathing, and I imagine probably a lot of you have these already, you can carry them on your keychain. Plastic mouth guards are helpful, and they'll make you more likely to do rescue breathing. But yes, essentially the three helpful things you can do for someone who's overdosing on opioids is give them naloxone, call 911, and provide rescue breathing. Any one of those things could be enough to save someone's life, but we encourage people doing all 3. The other reason I really like this slide is if you look in the bottom corner, there's a dummy giving their dummy friend mouth to mouth. I don't know why that cracks me up. It just looks funny. Okay, monitor the person until the help arrives. If there's no response after 2 to 3 minutes, give the second dose. Normally what a response looks like is sometimes people will just wake up as though they've been deeply asleep. Sometimes they will take a deep breath. Most likely, they're not going to realize that they overdosed. You are going to have to talk to them and explain what just happened. They just went unconscious. They're not aware that they weren't breathing, that they weren't responsive, and that you gave them medicine. Keep rescue breathing if they're not breathing on their own. I said this, but don't split up the kits. Give the second dose. Always keep 2 doses together. And actually, Chicago Recovery Alliance has started the practice of giving out 3 doses on the street to their participants, 3 doses and 3 syringes, because with fentanyl, they've seen that actually people need more than 1 dose to be revived. So medical attention is most important. People might be angry because they're experiencing withdrawal symptoms when they wake up, so try to stay with them, encourage them to go with EMS. Obviously, that doesn't always work. I'm sure we've all had times where we wish someone would go to the hospital, but they didn't. And so, again, there are a few reasons why we say medical setting is best. Is one, they can go back into the overdose. In a hospital, they can actually be put on a naloxone drip where they have a lot more control over how much naloxone they're getting. There might be other health issues, particularly with older adults, that we don't know about or that are going to be complicated by the fact that they stopped breathing for a little while. So it really is best to get someone to a medical setting. Here's an image of the rescue position. You want to turn them on their side, kind of put their arm over this way to hold their weight to one side. You can put something behind them if necessary. Here's a picture of what the rescue position or recovery position looks like. So I'll just say a couple things. I have syringes here. If you have never handled an intramuscular syringe before, it's okay. It's just a syringe. And I think we have a lot of stigma about needles. I think part of what we need to do is kind of work our way through that stigma about syringes, because while syringes are a way that people administer drugs to themselves, they are also the way that we administer helpful drugs like naloxone to people. So intramuscular syringes are not the type of syringes that people would use to inject drugs. Those are intravenous syringes. They have a much smaller needle. So these aren't necessarily like a risk for diversion, and if people are using these to inject their drugs, they're going to do a lot of damage to their veins, and I would encourage connecting them with a place like Chicago Recovery Alliance or some other needle exchange, so they actually have sterile syringes they can use to inject their drugs. So when you're holding an intramuscular syringe, you'll open the packet. That's pretty straightforward. Make sure you twist to make sure the needle is securely attached. So I'll just show you. These can twist off. And while they're not going to be like that loose when you open the pack, sometimes they can be a little loose. You just want to make sure they're tight. So twist it down, take off the cap, draw it back to like 1 or 1.5, whatever you want to put some air pressure in there. And when you stick it in, like I said before, you'll flip it upside down. You should be able to see the needle in the bottle. Push the air in, draw the syringe out, and the fluid will come through. Like I said, if you've never handled a syringe before and you want to play around with these, we have extra syringes, and you can play around with them. Why does CRA give out intramuscular syringes when there's other versions available in the world? Anyone curious? Cost, of course. Like, why do we do anything the way we do it in our world? It's cheaper by a lot. So actually, a two-dose kit, something like this, costs about $20. An intranasal kit, 2 doses like this, costs about $75. And the very fancy auto-injector that talks to you and tells you how to administer it, thousands of dollars, like $1,500. And so I know programs, for instance, I know a homeless shelter that did not feel comfortable giving their volunteers syringes, or they didn't feel comfortable asking their volunteers to use syringes. So they got a grant and they applied to get intranasal naloxone. You can find ways of doing this at your programs. Like, I think, much like a fire extinguisher, you got to make space in your budget to have a fire extinguisher. Make space in your budgets to have naloxone also, and buy the formulation that your staff are most comfortable with. That being said, take the intramuscular kit with you today. It's better to have the syringes in your bag and feel uncomfortable about it, and if you need them, you have them, and hopefully you never have to use them. So. This is the intranasal version. This is what the Narcan looks like. You literally, for this one, you open the package that it's in. This is an example tester one, and you just hold it in someone's nose and squirt it. I realize that sounds easier than the intramuscular version. Go find it. You can get it. Ask your pharmacist, ask your program to put it in the budget, whatever. But the intramuscular version, very free, so don't underestimate that. Here's a review of the steps. Stimulate. Call 911, administer naloxone, rescue breathing, stay until help arrives, 2 to 3 minutes, give a second dose, and then the rescue position if you leave them unattended. Obviously, if people aren't using drugs at all, they're at a lower risk of overdosing. I think that goes without saying. So we do want to support access to treatment, but we don't want to, I don't think we should pigeonhole ourselves into saying treatment is the only way to reduce your risk of overdose. That's what we're talking about, is even if you're using, you can reduce your risk of overdose. But for people who are interested in finding treatment resources, the Illinois helpline exists. It's 833-2-FIND-HELP. It's a very easy phone number to remember, even though I don't always remember it. And then the helpline.illinois.org, helplineil.org is where you can get the same resources. So if you want to find it online, or if you want to just call someone and talk to someone, that's what I prefer to do, to be honest. I like talking to people. Then you can get help finding treatment resources. They have very tailored, specific resources. And if you do encounter barriers like, hey, there's a 6-month wait list, like someone mentioned earlier, please contact us and let us know. Part of what we're doing to try to address the overdose crisis and the opioid crisis is increase access to treatment. And if that's not happening because there's just not enough resources, then I think it's important that we hear about that. And then I mentioned this already, but methadone and buprenorphine that are partial agonists, and what they do is they essentially help relieve the craving or the withdrawal symptoms that people experience when they're dependent on opioids. In doing that, they reduce people's overdose risk. So for whatever stigma still exists against medication-assisted treatment, people thinking that it's just swapping one drug for another, again, if our goal and our target is to reduce overdose death, we need to be willing to kind of embrace these tools that are out there. Drug overdose prevention program. You can be a drug overdose prevention program. Come find us. This is what our website looks like. IDHS Super, drug overdose prevention program. It's pretty straightforward. But on the website, you'll be able to find all the materials that you need to apply to become a drug overdose prevention program. What I will say, I'll say it now. I have trained several hundred people on how to administer naloxone. And I myself have never had to administer naloxone, thankfully. There have been times where I was worried and close calls and stimulating and monitoring, but I never actually had to administer naloxone myself. I have given naloxone to people who ended up using it on someone else. And so while it is very helpful for all of you to take a naloxone kit today, the most helpful thing you can do is get trained as a trainer or become a drug overdose prevention program, and you can start training the people in your programs, the people in your life, the people in your community, and give them naloxone. That is the most helpful thing I think you can do, is start by talking about overdose, then start by carrying naloxone, and then start giving out naloxone yourself. Naloxone is legal. There are no liability concerns, not for your program, not for you as an individual. How many people are direct service providers in the room? How many people are administrators in the room? Oh, fewer of you. All right, so all you direct service providers, go back to your programs and be like, hey, I have this naloxone kit now. If someone's overdosing on opioids, obviously we're going to call 911, but can I administer this in our program? Right? This is how we start the conversation in all our programs about what are we doing about opioids? Do we have naloxone available to our staff? Is it in our first aid kit? Do you want me to administer it since I'm a trained responder? Legally, you can administer it, but I encourage you to talk to your programs about it. And for your administrators, I think you get the deal. You should also have naloxone. Report within 5 days if possible. So I mentioned the naloxone you're getting today is coming from the Chicago Recovery Alliance. Jason over there at that table, he is a trainer with the Chicago Recovery Alliance also. And that is the table where you will get your naloxone today. There is a card in all the kits that has Chicago Recovery Alliance's information, I believe. And yeah, I see nodding. Okay, and so that is who you should contact if you need more naloxone or if you want to report using the naloxone that you received today. More resources from Chicago Recovery Alliance. They have a garage where you can go and pick up supplies. They can help you get started before you become a DOP program to make sure your staff is trained or that you yourself have enough naloxone or that you have access to sterile syringes. They also have interesting information on there about safer injection practices. There is a half-sheet piece of paper in your folder. This is the information that Chicago Recovery Alliance collects to make sure that they're documenting when they give out naloxone to people. So this is an anonymous code. If you have any questions about filling out this half sheet of paper, you can ask the folks over there at the table. They'll walk you through it. But basically what you have to do is fill that sheet of paper out, that half sheet, turn it in over there, and they will get you a naloxone kit before you leave today. A couple other final resources here. This is a video called Preventing Empty Spaces. You can go to this website, you can go to this link and watch the video, and it both introduces some people who have been personally impacted by overdose, which I think is helpful to contextualize what we're dealing with, that the overdose death doesn't just involve the individual, but it affects family members and whole communities. And I think that pain and trauma lasts long beyond the overdose event itself. And so this actually will also give you a reminder about kind of all the things you need to know to administer naloxone as well. So if you kind of tuned out the last 45 minutes, just watch the video. Or if you want a refresher, is a nicer way to say it. And then I already said, but the most helpful thing you can do is start getting naloxone into the hands of people who use drugs. And I think that is part of changing the stigma against people who use drugs. We need to stop thinking about people who use drugs as bad people or as just sick people or as addicts and start thinking about them as the people who are most on the front line of this overdose crisis. They are most likely to be affected, and they are most likely to be there when someone is overdosing and reverse the overdose and save someone's life. And even folks who are in recovery, I've talked to people who are abstinent and trying to maintain their recovery. They still know people who use, and their friends are more likely to call them up than they are to call 911 or they are to call us, and probably we're not answering the phone in the middle of the night either. Or hopefully not. I don't know what y'all do. But so I think just really important to drive home this idea that people who carry naloxone can be a hero. Here's the helpline website again. And thank you all for your time.
Thanks again, James, for the training. And let's have one more round of applause for all of our speakers and for SSA for hosting.